Yeah.
Yeah. Okay.
Good evening, everyone.
Good evening, Dalal sir. Good evening, Varghese sir.
Yeah. Thank you. Thank you.
A parallel webinar is going on, no, on child psychiatry.
I think we have about 3 parallel or 4 parallel programs going on today. Pretty loaded, fully loaded.
All the weekends are heavily loaded.
Dr. Dalal, good evening.
Good evening, sir. How are you?
I'm doing well. It's good morning for me, but good to see you, sir.
Everything is fine over there, sir? All well?
Not really, because we have 150,000 cases per day and almost 3,000 deaths per day. I mean, it's fine for us because most everything I do is virtual. We live in a very safe suburb and all of that. But if you live in the city, if you are someone who has to go out to work and all that, then it is very difficult right now. Lots of hope pinned on the vaccines.
Yeah.
Yes.
We started giving it, and I think about 1,000 doctors and nurses received it yesterday.
Yes. You had it, sir?
No, not yet. Not yet.
Okay.
I'm going to take it next week.
Okay. Okay.
Psychiatrists, are in tier 2.
Yes. That's right. But in a way, it is advantageous also, no? You come to know about if there are immediate side effects or something like that. Which
Exactly. So let our internal medicine guys be the first ones to get.
Yes.
They've had five cases of minor allergic reactions.
Yes.
For in the country. I don't think it is anything serious. They have given.
It's not at all that serious, sir.
Yeah, not at all.
Bell's palsy was something which is causing some concern, but I do not know. It may not be associated with that at all.
Yeah. As you know, there was one case of transverse myelitis in UK.
Yes.
But eventually, I think they decided it was not related.
Not related, yes.
So there are 31 participants now. Shall we start?
Yes.
Yes, we can start.
Shall we start, sir?
Yeah.
I'm ready.
Okay. Good evening to all the faculty and participants who have logged in for this very interesting webinar. It is my pleasure to introduce the topic for today. I'll just take a minute to share my screen. So the topic that we are going to discuss for today is nosology of schizophrenia and related disorders over 150 years. So just to briefly introduce the topic, although schizophrenia as a discrete diagnostic entity has been studied in depth in the last century, its core definitions, causes, and pathogenesis, in other words, its precise nature, continues to be debated. Although it has been defined as dementia precox by Kraepelin and schizophrenia by Bloiler, its varying definitions and boundaries of schizophrenia have kept expanding and receding over the last century. Thus, it is instructive perhaps to trace the nosology of schizophrenia from its evolution till the current DSM-5 and ICD-11, proposed ICD-11, and even beyond what the future holds for us. The current concept of schizophrenia heavily draws upon Kraepelin's formulation of dementia precox, which is based on course and outcome as a central defining characteristic. But before that, or up until then, there were two major prevailing constructs of psychosis. That is Gracinger's model of unitary psychosis, where it was believed that there was only one basic form of psychosis and all the different manifestations are probably attributable to the endogenous, a combination of endogenous and environmental factors. Whereas others have suggested that there are several distinct psychotic disorders and gave labels like catatonia, hebephrenia, Foley circulaire, dementia paranoidis, and melancholia. There are many key contributors in the journey of nosology of schizophrenia. Of course, we cannot forget the contributions of Emil Kraepelin, who believed strongly that course and outcome are central to defining and demarcating illness boundaries. Bleuler, who gave us the term schizophrenia, he believed that splitting of psychic functions was central characteristic of schizophrenia. And the gentleman on the right, Kurt Schneider, who believed that impairment of empathic communication was the central defining feature of schizophrenia, and he formulated his 11 Schneiderian first rank symptoms, which was given central importance in the present state examination and also figured in ICD-9, DSM-3, and also beyond that. So subsequently, from DSM-1 to DSM-4 and ICD-6 to ICD-10, all these elements of Kraepelinian chronicity, Bloilerian symptoms, and Schneiderian first-rank symptoms figured, but the relative emphasis given to these three routes did vary between these classificatory systems. Over time, definitions have become more narrow, more operationalized. Definitely, this has contributed to improving reliability in diagnosis. But of course, we know that there are several limitations too with the current classificatory systems, predominantly in terms of not being able to capture the heterogeneity of schizophrenia. Now we know that it's not just one illness, but probably an illness with several not entirely overlapping subtypes. And also the inability of the classificatory system to deconstruct the course of illness, both in terms of the whether it is a first episode or a chronic illness, or in terms of the current clinical picture, that is whether it is acute illness or in partial or full remission. And there are several limitations to the current classificatory system. So that's what we are going to discuss today. We have several eminent experts who are lined up today to offer their views on this topic. So it is now my pleasure to introduce the chairpersons for this session. Professor P.K. Dalal, sir. Sir is Professor and Head, Department of Psychiatry, KGMU, Lucknow. Sir needs no introduction to the psychiatric fraternity. Sir has a very rich teaching experience of 34 years, been a part of several international and national projects, over 100 publications and 4 book chapters. Sir has won several prestigious awards. And of course, Sir is currently the president of the Indian Psychiatric Society, and in the past has also held positions of president of IPS Central Zone, editor of IPS Central Zone Journal, and Sir has also been a member of many specialty sections and task force of the IPS. The other chairperson for the day is Professor Varghese Punus. Sir is Professor and Head, Department of Psychiatry at Government TD Medical College, Alleppey, Kerala. Sir is the General Secretary of Indian Association of Social Psychiatry and also held positions of formerly of President of Indian Psychiatric Society, Kerala Chapter, Editor of Kerala Journal of Psychiatry, and Associate Editor of the Indian Journal of Social Psychiatry. Sir has been a recipient of several awards like the Fellowship for Young Psychiatrists by the World Psychiatric Association. He has published more than 30 publications in reputed journals and has been a recipient of several other prestigious awards. His areas of interest are predominantly child and adolescent mental health and public mental health. With these few words, I now hand over the session to our esteemed chairperson. Thank you. Over to you, sir.
Thank you, Vikas. And the task has been given to me was introducing the subject which you have done. And I will request Dr. Varghese to kindly introduce Dr. Pandurangi. Before that, a few of my thoughts regarding this. I really find this word schizophrenia, I mean, how to spell it, what is the spelling of it, and all these things so complicated, and so is the disease itself. In MBBS, we used to ask the ward living viva, the students, still we are asking them that what is the spelling of schizophrenia. If you are really able to spell it correctly, then you are passed. So such kind of things are there. And then, as has been said by Dr. Vikas, that going from pre-Kreplelian to Kreplin, then all the other Bloiler, Schneider, and then then downwards with ICD 7, 8, 9, 10, and now 11 coming, and DSM 1, 2, 3, 4, 5. First it is broadened, then it is narrowed, and now it is broadening again, that schizophrenia as such, the other sub classifications have been done away with. Whether this is schizophrenia or schizophrenias, and as we draw the line starting from schizotypal personality kind of a thing to maybe something like brief reactive psychosis or maybe delusional disorders, and then going to schizophreniform psychosis, then schizophrenia, then schizoaffective disorder, then schizoobsessive disorder, then continuum schizophrenia spectrum disorders. So all these things are really very, very, I would say, intriguing, and no clear-cut thought process. And maybe NBN classification, neuroscience-based classification, where are we going through that? With the advent of neuroimaging, neurophysiology, neurochemistry kind of facilities are coming up. So can we have a better etiology-based classification of psychiatric disorders, including schizophrenia, in coming days? So all these things are because of which this wonderful webinar is being organized, and I really thank the organizers as well as the excellent presentators, including Dr. Anand. So I believe that it will be having a very good, historical and then continuum and future for last 150 years, and then what is there in store for us? What are the future directions of research, and where are we heading for really? And then I believe there will be a lot of information for our PG students who have logged in, and there I expect a good discussion, and there will certainly be definite take-home messages from this webinar. So I congratulate the organizers, and I am very, very sure that the speakers will do justice to their parts. And once again, thank you for having me over here in this wonderful webinar. Thank you, one and all.
Hi, good evening, dear friends, respected speaker, Professor Anand Pandurange, my co-chairperson, Professor Dalal, and dear colleagues and participants. I am extremely happy that I got this opportunity to chair this very interesting session by Professor Anand Pandurange. Since the most important part has already been done by Dr. Vigas and Professor Dalal, my duty is to introduce our distinguished speaker, Professor Anand Pandurange. It's only a formality because all of us have listened to him several times. He's a renowned researcher and scholar on schizophrenia in the international scenario. But for the demands of the situation, I make an attempt to make a brief introduction on Dr. Pandurange. He is currently the Distinguished Career Professor of Psychiatry Physician at Virginia Commonwealth University and Health Systems, Richmond, Virginia, United States of America. We can take pride in the fact that he had his early training in India. He did his UG training in JIPMER, and then he did his MD from NIMHANS, Bangalore, in the year 1978. Then he moved on to the West. He did a prestigious fellowship in schizophrenia research in the Department of Psychiatry at Columbia University, New York, in 1984. After his board certification in psychiatry and neurology, he went on to specialize in areas like psychopharmacology and transcranial magnetic stimulation. The awards he has bagged are innumerable, starting from the Young Investigator Award in Schizophrenia Research in the year 1987 to the Distinguished Life Fellow of the American Psychiatric Association, an outstanding psychiatrist, Virginia, to name a few. So he has been renowned as a very great teacher and a great clinician with a lot of scholarship in the areas of schizophrenia research. As already pointed out by Dr. Dalal and Dr. Vikas Menon, the nosology of schizophrenia has been baffling. When you train your UGs or even the first year resident in psychiatry, it's a big task to make them capture the real complexities of what schizophrenia means. We try to make it simplifying, make it simple stating that schizophrenia is a psychosis characterized by delusions and hallucinations. Then we try to tell them that, okay, it has got negative symptoms and cognitive symptoms. These are all part of schizophrenia. But at the end of their brief training, they are still confused. And even after several years of training, people cannot put it like very clear things like whenever you study science, it has to be simple. It has to be like with an atomic number, atomic weight, one has to it's easy for somebody to understand chemistry because everything is in the periodic table clearly written. And from our medical teaching and neurology side, when the neurologist says that there is a syndromal diagnosis, then there is an anatomical diagnosis, then there is a diagnosis based on pathophysiology, it becomes it's very clear and concrete, and it is so appealing to the young brains who are attempting to study science. But when it comes to psychiatry, when we start talking about the complexities, there are several schizophrenias. It has got several domains. It can have cerebral localizations in the neuronal circuits. Ultimately, it leaves a very confused young scholar. Anyway, I think we need a mind. We need a different set of attitude to understand the complexity of a very enigmatic process like schizophrenia. So today we are fortunate to hear from one of the masters. We can hear from the master. Over to you, Professor Pandirange, for your presentation. Thank you.
Thank you, Dr. Varghese. I appreciate it very much. Again, good evening, everyone. It is indeed my pleasure to be a part of this program. As I often say, my head is in the USA, but my heart is always in India. Whenever I get any invitation from JIPMER, NIMANS, or PGI, I always say yes. The institutions with which I'm more closely associated, but over the years, I have psychiatrist colleagues and friends virtually every corner of India and every city. So it is indeed a pleasure for me to be a part of such programs. I want to thank Dr. Tripathi and Dr. Menon for organizing this and inviting me, and Dr. Dalal and Dr. Varghese for chairing the session, and Dr. Grover and Dr. Tripathi, who will later be moderating the question and answer panel. So thank you all. And last but not the least, to all the participants who have logged in, especially the younger folks. I understand it is Saturday evening for you guys, and you might be wanting to do some other more interesting things than hear a lecture on schizophrenia. But nevertheless, we'll try to make it interesting. So with that, let me share my screen. Okay, I hope everyone can see it.
Yes, sir.
Yeah. Okay, so I want to give an outline of this talk. I have about 35, if I push it, maybe 40 minutes to do this. And so the first first set of slides is about what Dr. Vikas Menon was talking about. And that is, I firmly believe that we should all know the history of psychiatry. We should know our roots. We should know where we came from in terms of our thinking. And that is the foundation on which we should build all new knowledge. Without that foundation, I think we will be floundering. And so the first section will be a little bit of a repetition of what Dr. Menon said, Dr. Vikas said, but maybe I'll give some more personal details. The second section will be about the various related disorders. And the third section will be about our attempts at understanding its biology and where it has taken us so far. And the last section will be what the current scenario is like in terms of understanding the idiopathology of schizophrenia, not so much all the findings as much as the approaches. So with that, some of my slides are very busy. They are meant for me to read, and I don't plan to read all of it. But we always like to say, schizophrenia, this is an ongoing discussion. Is schizophrenia a new disease of civilization, been around only for 200-300 years? Or is it something that has been there forever, as long as mankind has been around? And there are mentions made in even the ancient scriptures, like the Atharva Veda, in the Charaka Samhita, and so on, as well as in literature from other countries such as China and Greece, where there are descriptions of madness or insanity or deviant behavior, some of which, not all of which, but some of which could very well be descriptions of what we today call as schizophrenia. So we don't know exactly the origins of this. If you know Fuller Torrey and his work, he believes it has been around only for 200-300 years, especially after people started to domesticate cats. But if you look at Chetan Haldipur's work, who is in Syracuse and has been writing extensively on the history of psychiatry from an Indian perspective, then you'll get a very different picture. In the recent years, as in the last 200 years, people began to describe in a little more descriptive way on these conditions. Again, without going into all the details, I would just highlight Esquirol's monomania concept, which is more like, I would say, something like either delusional disorder or maybe obsessive compulsive disorder, because he largely based it on a few patients, especially one patient that he had, who's on retrospective review appears to have more of an OCD type of disorder. He said, in this insanity, a person's mind is largely clear except in one or two areas. So Kalbaum was probably the first to more formally use the term paranoia and describe it. He also later described catatonia. And Hecker was probably the first to describe what today is called as disorganized schizophrenia. So these descriptions all occurred in the 19th century, in the middle of the 19th century, and that is where we start our journey with our modern journey with schizophrenia. As was mentioned earlier in the introduction, there were some very strong schools of thinking, especially the Greisinger school and the Kraplinian school. Wernicke was another strong voice, and they did not necessarily agree with each other on what schizophrenia was or what this chronic psychotic condition was, and these views prevailed. There is some importance for us to remember this history and to actually articulate it, because even today we really don't know exactly what the boundaries of schizophrenia are. And it is important to pay attention because all these were astute clinicians who actually based their views on direct observation of patients over their lifelong careers. And so these things cannot be dismissed as simply historical, but they need to be kept in mind as we look for the etiology and pathology of schizophrenia. So Emil Kraepelin, often recognized as the father of serious mental illnesses, certainly for schizophrenia maybe, believed that schizophrenia was most likely a single disorder, as he articulated in several of his works, especially his textbook of psychiatry, and basically said that from a pathological point of view, this is a single disease. And as Vikas was saying, he anchored it in the course and outcome, much less in the symptomatology. As you may know, that he hired Elua's Alzheimer to find the pathology of schizophrenia, and Alzheimer's findings are considered to be relevant even today. I am a big fan of Kraepelin, and I made it a point to visit his cemetery in Heidelberg, Germany, where he is buried, as well as visit his Institute of Psychiatry. There I am standing next to Emil's tomb, and on the left side for my left side, is the Institute of Psychiatry. Interestingly, when I went there was a lady out there for her smoke, and we started chatting, and she asked me why I was taking pictures of the building, and I told her that this was a very famous building that had undergone some renovation, and I was a fan of some of the work that had been done here. She was a patient apparently there, and she did not know the history, and she was very excited to know that she was receiving treatment at one of the most famous institutes in the world. Bloiler was more or less his contemporary and had a somewhat different view. They corresponded quite a bit with each other, and they did actually agree on some of the issues, but they also disagreed in the fact that Bloiler thought schizophrenia could occur much later, that the overall prognosis can be better than what Emil Kraepelin said. Kraepelin had believed that about 85% of people decline, only 15% make it out of the asylum, whereas Bloiler's numbers were somewhat better, and that this is not a single disease. As Dr. Dalal mentioned, this is schizophrenias in the plural, and he focused, as we all know, more on the symptomatology and the schisms in the thinking and affect and perception. So that book was actually published in 1911. Kraepelin's 8th edition was 1896, and of course the English translations came out later. So this was a slide that I borrowed from Jeff Lieberman. It's a schematic that there is a decline from the premorbid phase gradually down into the residual phase. This is a lifelong disease. So this is a sort of a neo-Kraepelinian conceptualization of schizophrenia. It's not all the way down to a purely dementia status, dementia as in the deficit syndrome status, but clearly schizophrenia continues to be defined with some decline as a fundamental feature of this disorder. Luke Ciampi and many others have done these long-term studies, including, I will mention this name a number of times in today's talk, Kenneth Kendler, with whom I work. I'm very fortunate to have him as my colleague. Have done a variety of follow-up studies. This one is from Ciampi's famous lecture that he gave at the Maudsley Institute and eventually published in the British Journal of Psychiatry, showing different courses, but all of them have some degree of decline. And broadly, when we teach students, we say that 1/3 of patients with schizophrenia do well, reasonably well. Another third require a fair amount of support, and unfortunately, the 1/3 or the last third really decline. So every now and then, I have inserted my own studies into this narration, and we conducted a study looking more at the schizophrenic deterioration. You may be familiar that Bloiler said, and I think it holds true largely even today, that most of the deterioration in schizophrenia occurs in the first 5 years after the overt symptoms begin. And we were looking at duration of illness and deterioration in 2 different samples. One was a university sample of patients. By definition, they are less sick, and one was a state hospital sample, which is more sick. And yes, we were able to demonstrate in this study, and that first one, that the more severe illness is associated with greater degree of dystrophy on brain scans. Those days I was using a computerized tomography. And in the other study that actually preceded this one, which was done at Columbia with Ron Reeder, Mukherjee, Robert Bilder, and myself, also we were able to relate the amount of deterioration that occurs to structural findings. So you will hear me talk more about this when we talk about the deficit syndrome. And it appears that, and when we talk about Timothy Crow's type 2 schizophrenia, that this subtype or subgroup demonstrates more decline and more structural changes compared to the other groups. Now, one of the issues that has burdened us and challenged us all along is the boundaries of schizophrenia and what to do with disorders that are not necessarily fitting the complete picture as Kraepelin or Bloiler described. And foremost amongst them is catatonia. Then there are the so-called reactive psychosis and a variety of other entities that I will mention quickly. So catatonia was described most clearly by Kalbaum. It has gone through a number of different iterations, and most recently, I think DSM-5 eventually has, in my opinion, accorded the status to catatonia that it has always deserved, that it can be associated with another mental disorder, but it can also be an independent entity by itself, whose etiology we do not actually know. We wrote a chapter, Dr. James Levinson and myself, on this aspect of catatonia. And what I have shown here, what we proposed was something, again, I think we as clinicians all know, that the prognosis of the catatonia depends on the associated condition, going here from depression, depressive catatonia, bipolar disorder, depression, and more independent or idiopathic freestanding catatonia, catatonia associated with schizoaffective disorder, and then catatonia associated with schizophrenia. So the prognosis goes based on the associated condition. Reactive psychosis, which is a topic very close to my heart because that was my MD thesis in NIMHANS. And again, without going into all the details, clearly the Scandinavian psychiatrists led by Stromgren and Jaspers and Wimmer and so on believed that what Kraepelin described as manic depression and schizophrenia did not cover all the psychosis, and therefore we needed a third psychosis, and that would be the reactive psychosis, sometimes called psychogenic psychosis because it is often associated with stress. Later on became, of course, as you know, brief reactive psychosis and brief reactive psychosis. and in the ICD more as ATPDs, which is kind of a little bit of a tongue twisting for me to say it. So we'll skip these. These are our publications that I was had the privilege of working with Dr. Kapoor in NIMHANS, and we published this in British Journal and in ACTA. We had 30 patients each, and by and large, I think even today people will agree that about a third of all these people will eventually turn out to be patients with schizophrenia. About a third may go to have some type of affective disorder, and a third remain as independent. They may have a recurrence of the reactive psychosis, but they actually prognostically do quite well. I just now finished reviewing another article yesterday that has been written by some Scandinavian group that I was asked to review, and they report about 45% convert to schizophrenia. Then there is the group of cycloid psychosis, and again, without going into all the details, it seems to be yet another entity that does not fit that of schizophrenia or even of manic depression, and has been articulated. If we know this entity, we recognize it. If we don't know this entity, we tend to club the patients into bipolar disorder or schizophrenia. But knowing it, I do see quite a few cases, maybe about 5% of our psychotic population, we see the more cycloid psychosis type of patients. Again, all of this is important because their etiologies may very well be different, although the final common mechanism may be maybe the final pathway may be common, their etiologies may be different. Schizoaffective disorder was described in the 1930s as some type of an admixture. Again, after detouring around a variety of descriptions, I think DSM-5 has probably gotten back to where it started, namely, it is much better to take the lifelong history of the patient in arriving at this diagnosis. Schizophreniform disorder, again, has been used differentially. I think you may have, some of you would have read the correspondence between Langfeld and Robert Spitzer. At the time, Spitzer created schizophreniform disorder in DSM-3. And Langfeld severely objected to the use of the word schizophreniform because his conception of schizophreniform was quite different from the way it is written in the DSM. I was very fortunate to have my office at Columbia next to Bob Spitzer's office. So I frequently ran into him, walked into his office, chatted with him, etc. And I asked him how did he feel about Langfeld's comments. He didn't really have much to say other than, well, you know, that guy's an old goose or something like that. It was fairly dismissive. Anyway, Vikas mentioned Schneiderian thinking and the role of, volition and ownership of thoughts that was important to Schneider as the key features of schizophrenia. We've had a lot of interesting discussion between Ken Kendler, myself, and others. When I was on the DSM-4 task group, there was quite a bit of discussion on whether to keep giving them extra weightage or not. Both Kendler and I argued that we should, and it was kept. But in DSM-5, Carpenter and Rajiv, they thought that was not supported by the evidence any longer, and have taken that extra weightage given to them out in DSM-5. Briefly, pseudoneurotic schizophrenia was more prominently described here in the US, pseudopsychopathic in UK. These are all on the fringes, and today would go under different names like borderline personality or schizotypal personality. And they are important because patients present in a way that could be confusing to the clinician. If you're a research clinician and you wrongly group them, that may cause us problems in deciphering the pathophysiology or the etiology. That takes us into the 70s when all of this became obvious that people were using different criteria across the continents to make this diagnosis. The more famous of these studies is the cross-national study, and eventually was put to rest after the IPSS study was done. But nevertheless, it makes the point that there can be much difference simply because of the training people receive and the way they apply the criteria. So, moving to the next section, where did all of this lead us? By 1960s, basically nowhere, with the confusion still being there about these multiple entities. And so a different approach was taken that why not we be much more quantitative in our approach? Why not we measure the symptoms? Why not we apply more statistical analysis? And that started the factor analysis approach. Present status examination has a built-in software, as you know, to arrive at symptom clusters. BPRS, or the Brief Psychiatric Rating Scale, which started from nurses' ratings of patients at the NIH research unit for schizophrenia and psychosis, which later has become morphed into the larger, bigger PANS scale, which is now the standard. All of these are constructed and have statistical validity to them and show that there are several clusters within schizophrenia. So we were one of the earlier group to offer a 3-factor solution at Columbia, which was published in the Schizophrenia Bulletin, where we had a positive factor, a negative factor, and a cognitive factor. Others have had a disorganization factor, and the PANS has a general pathology factor as well. So this approach did not actually lead to specific categories of diagnosis, but started to deconstruct psychosis into various subsyndromes. Carpenter had 4 of them, one of them being the social dimension in addition to these. Others, I think it may be coming down in another slide, Schwang and Winokur and Tim Crow have their own typologies. And based on this emerged the more modern way of diagnosing, or the diagnostic criteria, from the Eli Robbins, Sam Guzay group, who published their Gold Book, and so-called Washington University criteria, or Finer's criteria, and then the Spitzer's group published the Research Diagnostic, or RDC criteria. These are based more on more structured interviews, capturing all the symptoms, meeting certain criteria, rather than clinical impression, to overcome that diagnostic differences between countries and different training institutions. And DSM-3 kind of was the watershed mark for all of that. Those of us who trained in India, this was not all that surprising nor very new. When I went to Syracuse and DSM-3 had just come out and there was so much excitement, I really was not sure what the excitement was all about, because in NIMHANS we had always taken a strong phenomenological approach and identified the symptoms and applied strictly the criteria before making a diagnosis. So I wasn't so sure exactly what the excitement was all about here in America. In DSM-5, they have the following traditional disorders that are listed on the left side, and then they added some new categories: the schizophrenia spectrum and other related psychotic disorders, specified and unspecified. As I said, they gave catatonia a place. And then they also have some diagnosis in the appendix, such as the attenuated psychosis syndrome, persistent hallucinations, delusions with some mood changes, shared delusion disorder, etc. So I continue to feel, however, they have left out a few things. One of my favorites is the so-called anxiety psychosis. I see patients who have a psychotic level of anxiety, paranoid ones, but they seem to have an anxiety disorder that is not covered. The whole entity of what happens with OCD goes on to become psychosis, or OCD with psychosis concomitantly remains an open question. Cycloid psychosis remain poorly understood and poorly not identified, poorly identified in DSM-5. So there is much more work to be done in terms of all these psychoses that are on the margins. There are other issues with DSM-5. While they have been heavily oriented towards published data, and I certainly appreciate the attention given to catatonia and the return to schizoaffective disorder the way it was originally described. What happens here, which we published in the Asian Journal, is there are some limitations to this and some drawbacks. And one of them is there a risk of overdiagnosing this in people who experience a variety of psychosis-like phenomena, but who may retain insight? Will minority populations be affected differently? What about populations where, in fact, the Schneiderian symptoms have a special role? And why do away with the subtyping? Will that take, while it may not be very useful right now from an etiological standpoint, from a understanding of the psychopathology and working with the patient and within a specific culture, those things may very well still be very relevant. And so I've had this ongoing dialogue with Rajiv Tandon about this, and the result was this publication in the Asian Journal. The role of culture has been much more recognized in DSM-5 with a very strong cultural formulation, but still, I think a lot of this depends eventually on how well a person is trained, how much time you have, how much you know about that culture. Simply having a formulation given to you is not sufficient. And we had mentioned this in an article that I wrote with Yakin Adibigbi, who is from Nigeria, way back, and in my mind, it still remains an issue. So moving to the third section, I'm not covering a variety of things associated with etiopathology. So in terms of disclosure, I don't cover these. There is not sufficient time to go into all of that in this lecture. Seymour Kerry, who is considered as the father of biological psychiatry, said that basically when the normal functions are disturbed by one or more of a variety of etiological factors, not a single common factor, but a variety of etiological factors, we might see what we call as the overt behavioral symptoms of schizophrenia. And there may be differences because of the underlying etiology, or there may be differences because of culture, or because of treatment and the context in which this is all being evaluated. So a variety of factors go into creating the heterogeneity. This, of course, has been recognized to some extent. I mentioned this. And I think the most prominent one is Tim Crow's typology, which I think tried to bring the etiology into this, at least the pathology into this, that type 1 will respond to antipsychotics better than type 2. Type 2 has more structural changes than type 1. They can coexist. And then the more symptomatological ones like positive and negative symptom, negative schizophrenia and deficit and non-deficit schizophrenia and so on. Again, I've not covered it comprehensively, but these are the more prominent ones. So what Dr. Kendler has said basically is, look, we thought there was a single condition, single etiology. We have gone from there into thinking there may be many, 2, 3, 4, but maybe it's a lot more than that. And as you know, he is one of the very prominent, foremost psychiatric genetic researchers in schizophrenia. And you may know that in 2014 and publications since then have identified many independent genetic loci that may be associated with schizophrenia. This number 128 was in their original set of publications, but that has changed quite a bit and has gone up over the last 5 years. But at least 108 of these, when more conservatively defined, have been there. One of the most interesting things is, if you look at that graph, and I didn't have time to put that into this lecture, that slide that Ken shows often in his talks, is the one that stands out most robustly is on chromosome 6 and associated with the histocompatibility complex, which modulates immunity. And that has gathered quite a bit of steam over these recent years as one of the possible etiologies, or at least pathophysiological mechanisms that we can take from the chromosome 6, maybe the histocompatibility complex, to certain inflammatory processes, dysregulation, cytokines being high or low. I'll say something more about it in the next slide. And then coming out in terms of the various symptoms. So Peter Buckley, who has written extensively, and I'm fortunate to be working with Peter. He is our dean currently. It's good to have a psychiatrist as the dean. And we wrote a paper in 2019 in this. Broadly, there is a blunting of the type 1 immune response and overactivation of the type 2 response. This is the broad suggestion when it comes to the immune dysfunction in schizophrenia. And it is more, type 1 may explain the fact that somehow inflammation goes on for a long, the more acute inflammation goes on in a strong way, and may very well be related to the more acute processes, the greater disorganization, possibly even the early positive symptoms. And type 2, the blunting may prolong the more chronic inflammation. It may not inhibit the inflammation and stop it, but may promote chronic low-grade inflammation and may be related more to the negative symptoms and deficit symptoms and so on. So there is quite a bit of literature that I reviewed for this paper. There may be some of you who are working on this, and I think it's published as a series of articles on inflammation and schizophrenia. I would recommend reading that. Sorry about that. Then there are the structural findings, which of course by now are well accepted, starting from the late 1970s and going until now. We began our work in actually a small amount in NEMANS itself, but at that time I was using pneumoencephalography, which article was published in the Journal of Clinical Psychiatry with a focus on tardive dyskinesia and brain changes, and then went on at Syracuse to CT studies, all of which essentially were able to replicate that Eve Johnson and Timothy Crow's group had published and Weinberger had published by that time about the enlarged lateral ventricles, the decreased brain size, and then with more recent MRI studies in the 90s and in the first decade of the new millennium, we know now that this is coming largely from loss of neurons in the prefrontal cortex, maybe the hippocampus and the medial temporal cortex, and some in the reduction in the thalamic size. The issue of cerebellum and its changes remains somewhat open, but we did find that in our studies. All of these were published in the 80s in the British Journal, in ACTA, Biological Psychiatry, so on. So I was very proud to be associated and contributing to this type of findings in the understanding of schizophrenia. Then there is the chemistry part. Let's see, what time do we have here?
It is 7:56, sir. We have some time.
We have time now? Okay. So the chemistry part is also a very interesting story, starting in the late 50s after the discovery of the antipsychotic drugs, and then driven by Arvid Carlson's work on what exactly happens within these neurons with regards to dopamine. And then in the last 20-30 years by Abu Darghami's work, which I think has shed a lot of light, and also Saul Snyder, and our own Kshitij Kapoor. So basically, as of today, I think it stands that there may be a final common pathway in the psychosis circuit that I will show you in a minute, that has some overactivity of the dopaminergic system, and that can be quietened or controlled by antipsychotic drugs. But clearly that is only more of a final mechanism and not the only mechanism, and that there may be more fundamental processes driving it. So the MRI work, the fMRI work, as well as some postmortem work, has come up with what may be called as the 1 or 2 psychosis circuits, based on largely on the neurochemistry and some histopathology. And that circuit may be, for simplistically described, as starting from the thalamus to the prefrontal cortex, through the cingulate to the associative striatum, and back into the thalamus, which would be one psychosis circuit. And another one may be from the thalamus to the limbic system and back. So these two may be the key circuits. There may be one that goes down all the way to the back to the cerebellum, which would be the third one. So there may be at least 3 relatively clearly identified circuits, of which I think this one is the best established one evidence-wise. And this becomes important for us from a nosologic and diagnostic point of view as we move towards the RDoC approach. So this is another schematic of the same thing, the thalamic, cortical, limbic, striatal, coming back to the thalamus here. And one of the things that we have learned as we move from pure gross structural abnormalities by CT and MRI and into these circuits is the availability of what is called as diffuser tension imaging, or DTI, and our ability to outline the tracts, the connecting tracts, and whether the abnormal function is coming out of the neuronal nodes that I showed you in that circuit, the dorsomedial nucleus of the thalamus, for example, or the dorsolateral prefrontal cortex, or the anterior and middle part of the cingulate, structurally speaking, or their interconnectivity through the white fibers, white matter, or both. And from that arises this connectivity hypothesis that schizophrenia may be almost like a reminiscent of the Bloilerian kind of thinking, a disconnectivity syndrome, that there is a disconnection between certain key functions, functional circuits. So, I won't have time to go into all the details, but it appears that at resting state, the default mode circuitry is more active in patients with schizophrenia. And this network is related more to internal attention, to internal analysis, introspection, internal monitoring, and so on. And there may be hyperactivity of this. Are patients with schizophrenia more prone to looking inside more, but in a very disorganized way, which ultimately overwhelms them? Recall what has been said about the origin of paranoia or paranoid symptoms. There is an arousal state. There is a state of overwhelming stimulus input, resulting ultimately in disorganization. The brain is unable to handle that. It puts it together as best as it can, which turns out to be wrong or false or misleading, which we call as delusions. So it is possible that some of this disconnectivity is coming from the fact that whereas one network is overactive, the more network that inhibits it, that involves the frontal cortex, for example, may be underactive and is unable to do so, unable to control it or inhibit it. There has been an attempt to put all of this together. Again, a busy slide that I've borrowed that will say, and I like this one because it really tries to bring in the totality of all of these, rather than, elephant with four blind men. We'll look at the chemistry and come up with a theory. We'll look at the structure and come up with a theory. We'll look at the fibers, come up with a theory. This one tries to bring everything together in this single slide, including the phase of life for the person and in the context of the illness, premorbid, prodromal, the overt illness stage and the residual, the phases of the neuronal evolution or development from the cells being born, differentiating, developing synapses, having too many of them, pruning them, myelinating the fibers, by which time they're ready to take on this phase, maybe around age 13, 14, or early to middle adolescence, where various stresses and life events begin to happen. And then, because they are not optimal in either their pruning process or in their myelination process, or just the membranes are not healthy enough and are becoming dystrophic, all three are possible. leads to the overt symptoms. And so I think that is one way of looking at it. This is a little bit of a diversion. I'll come back to where I left the other slide. But to those PGs and others who are interested, I thought, let me just throw this one in as well. While we all talk so much about biology and neuroscience and MRIs and fMRIs, there has been another parallel of looking at this entity called schizophrenia completely differently. I went to Syracuse primarily to see what the heck Thomas Szasz was talking about. I had an opportunity to go to several different programs I could choose when I moved from NIMANS to USA. I chose to go to Syracuse in part because they said I could continue my research, but in part it was because Thomas Szasz was there. So I interacted with him for 3 years. And as you may know, he has a very different view of this whole condition. And then you obviously, Lang, who I think has a much more interesting theory of being hypersane. That is this whole process that I just described to you of the default mode network being overactive and one's ability to introspect being very active. What if it was not so berserk as we think it is? And even if it is berserk, so what? If it is actually getting at what he thinks is the truth or reality. If you read his books, I think, I know he died, but if you read his books, you'll get a sense of how the disorganized mind thinks and perceives. I just want to throw that in so we don't completely forget their contributions, as well as the others that I won't have time to go into this one. I listened to some very interesting debates between Dr. Kendler and Theodore Lids on this one at some of the APA meetings. So that brings us to the last section, namely the RDoC approach. That is, okay, we have all these typologies, we have all these syndromes, we have made major attempts at biology. Even in our Syracuse study, we measured dopamine beta hydroxylase, we measured catechol O-methyltransferase. In studies at VCU, I measured dopamine receptors on platelets with Dr. Chari, Narasimha Chari, very well-known biochemist who was working with us at that time. He is no more. We looked at dopamine counts. True, and I'm just mentioning my work, but obviously there have been tremendous work by others, much more bigger and major than my little thing. However, none of them have given us a diagnostic test. None of them have given us a real prognostic test. None of them are at a point we can use it for individual patients or talk to family members. And so NIH was very frustrated with money they were putting in and getting nowhere, and therefore the RDoC approach. That is, let us deconstruct these syndromes to the most basic level possible and look at, start more or less from scratch. And one is the NIH, not NIMH, but NIH, Neurology Institute, their main big project on identifying every single type of cells in the brain. The other is the Connectome project that attempts to outline every single tract in the brain. Give you a second to look at this. 89 billion neurons, 1,000 to 10,000 synapses for each of them. You do the math. And outline each of these tracts as clearly as we can at the, if not the microscopic level, at least at the circuitry level, something like this. So if we can get a better grasp of the cells and a better understanding of their connectivity and relate that to syndromes broken down to their most basic elements as affect, fear, anxiety, tension, ideation, pre-ideation, ideation, sentence, language, expression, connectivity between expressions or so-called loosening, so on. Similarly, break down hallucinations and try to create a construct that attaches the neuroscience part of it, the cell type, the circuit type, the latent function type to the more overt function, and then to the behavior, and then to the syndrome. Not a disease like schizophrenia, but a small construct syndrome. That is the RDoC approach. And then there are other approaches which are also ongoing. This is a machine learning approach where scans are obtained. This particular study uses the surface morphometry as opposed to the voxel-based morphometry. And essentially what they are looking at is minor variations within a group, and whether when put together they could arrive at some kind of an arithmetic formula that will help us categorize people. It is something like the analogy I like to give for this type of approach, which is ongoing, is think about height, and there is a tall person and a short person, or a group of tall people and a group of short people. And let us say they, on average, they differ by 12 inches, 5 feet and 6 feet. Where is this difference coming from? Are we to divide, let's say there are 100 body parts, and are we to divide the 12-inch difference exactly into 100? 12 divided by 100, is that the difference? Is every part of the body exactly the same amount less in the shorter person than it is in the taller person, or are there variations? That is exactly what they're doing here. If there is a gyral change, either in the size or in the thickness, what is it? And is it common to schizophrenia or bipolar disorder or the healthy adults? They also had the Tourette syndrome group here. And are there patterns? And this is one of their final slides, that in fact there are patterns, and that they can decipher, that they feel can categorize people about 85% to 90% correctly with what clinicians have done, although this is more or less opposite to the RDoC approach. So this is the back to the category approach that we will use our current tools or finer tools to measure the brain as finely as we can, and then find the patterns and classify them. Whereas the other approach is we break it down as much as we can into dimensions and into latent concepts and latent functions and circuitry and cells, and then we will go that way. So I'll finish up here without going into the details. This can be done with auditory hallucinations into 3-4 factors maybe. This can be done with negative symptoms, at least 2 broad factors. And then you can look at their functionality, how they image on an fMRI. You can look at chemistry possibly, but certainly you can look at electrophysiology. We may be able to look at something with magnetic stimulation as a probe as well, in terms of their excitability and their inhibition status, or the latency with which they respond, those circuits. One could use also TMS as a probe. So there is imaging, there is chemistry, there is a magnetic type of stimulation one can use to further probe into these. The last one or two slides are on negative symptoms. I will not go into the details. More or less what I said applies for hallucinations, applies for the negative symptoms as well. As you know, DSM-5 has identified two of these, the evaluation factor and the emotional expression factor. There may be another one. I'm not sure that sociality can be put so clearly into this. So maybe two, maybe three. And there is some evidence for that in terms of the imaging studies. There is some abnormality here, for example, in the inferior longitudinal fasciculus that is shown here, as well as the arcuate fasciculus, which is shown here. But there is some evidence for these types. It's still emerging. Keep in mind the RDoC approach is only about 4 or 5 years old, maybe 6, and so we don't know. Anyway, I want to end on two questions. One, is our glass half full or half empty? Have we made any real progress in 100 or 150 years from 1850 to now or 1870 to now? The answer is yes and no. Here is a study that Baldessarini and his group did. They identified all the studies they could get their hands on, 821 studies. Finally, they took 320 of them, 51,000 something, 52,000 patients. 40% of patients with schizophrenia were considered improved. Well, how much of that is a progress from what Bloiler said? And the proportion depends on how you interpret the criteria. Broader the criteria, as Bloiler did, greater the improvement. Narrower the criteria, as Kraepelin did, lower the improvement. Somewhat different from Kraepelin's 15%, but here we are at 35%. So you decide whether we have made progress in a century plus working with this rather challenging, interesting condition called schizophrenia. Now we have this so-called recovery approach. I wanted to leave on a positive note, just not raise questions and leave the talk. And we wrote an article in Amresh Srivastava's book on recovery on this, that we have to, and in India, I think this particular type of work is quite strong because of the Schizophrenia Foundation and the Richmond Fellowship and so on, that ultimately what we call as schizophrenia recovery is something that is not just symptomatic recovery or even functional recovery. Recovery of what is lost in schizophrenia is actually humanity, dignity, and respect. When a person, 18 years, 19 years, 20 years, begins to experience these rather bizarre experiences of hearing voices or getting confused, believing in things that may not be true, etc., and people begin to look at the person differently, he or she loses something much more vital to them. And it is recovering that really counts ultimately. I have any number of patients. I've been fortunate to stay in one place for the last 36, this is my 37th year. So I've seen people who were 18 years and 20 years when I first picked them up as my patients, who are now 55 and 60 years of age. I've seen them, quote unquote, recover. And what I have found is that while their function is recovered somewhat, their symptoms are recovered somewhat, what they have recovered really is their dignity and respect. So I want to share that with especially the younger group that may be listening into this lecture, that when you work with your patients, while we will all do MRIs and we will do the antipsychotics and we will do the psychotherapies and all of that, keep in mind that your long-term prognosis of your patient is to a large extent in the hands of the patient. and you have to support him or her to recover that most vital part of themselves, namely their dignity and respect. Thank you very much for your attention. I'm open to any questions that might come up in the next segment. Because I'm done.
Yes, sir. Would our chairpersons like to offer some concluding remarks before we move to the questions in the open house?
Dr. Pandrange has given a very comprehensive account from the history, the way in which schizophrenia research has progressed from the phenomenology to the structural, from genetics, and finally to the inflammatory kind of thing. And he has taken us from the Kraplinian type of classification to the research domain criteria with neurobiological pinning. So this has been an excellent comprehensive description of what has been happening over the last one and a half century. Now I think there are many questions, and the moderator, I think Dr. Vigas is moderating, and Dr. Sandeep Grover and Dr. Adas Tripathi are handling the question and answer sessions. Professor Dalal, for any comments before it's...
No, only that it is an exemplary presentation as usual by Professor Anand, and as you have said, a very comprehensive presentation. And I would say we are progressing. It is not that it is the glass is fully empty, but it is half full. I would say that we are progressing. Time it is going to take. I mean, we all know that brain pathology and all these things, the description and all these sophisticated instruments, investigations and procedures and all these things are going to take time, but still we are progressing. And yes, we do get patients who are, say, good prognostic ones, so improve almost completely at times. So picture is not that gloomy, I would say. And I congratulate Professor Anand for an excellent presentation, and hand over the mic to the moderators for having a good discussion. Thank you.
Thank you, sir. We just take up a few questions in the order of importance. I think some of the questions which have been posted were in the early part of the session, and subsequently in the talk, sir has already answered probably through his presentation some of the questions. But there is a question by Dr. Swapnajit in the chat box that what is the status of pseudoneurotic schizophrenia today? And are we not going to forget all the previous classic types of schizophrenia which we sometimes see in our practice? So I think question is basically about the merits and demerits of excluding the subtypes of schizophrenia as from DSM 4 to 5. Anand sir, Pandrange sir, your thoughts on that?
Yeah, so it depends on what is your role. If you are a schizophrenia researcher focused on a particular hypothesis, then these things are not all that important to you. Where is what was previously called pseudoneurotic schizophrenia, where is the subtypes of schizophrenia. But if you are like me, and I call myself a clinical scholar rather than a pure researcher, in other words, I crisscross all the time from the clinical world to the clinical research world, back and forth, then these things are important. The reason it's important, and I think the more senior people on this panel and in the audience will all agree with me. I see there is Mohan Das, I know Sandeep is there, Dr. Dalal, Dr. Varghese, many others, Dr. Tripathi. So see, what happens is patients come to us with these presentations. Patients are not going to come to us with a label. They come to us with different experiences, and we have to interpret it. And if That's why I like to keep this, and I explain to them that 20 years back or 40 years back, you might have been called this. And today we will call this, but don't worry too much about the diagnostic label. It is your experience that is more important. So I say to the person who asked the question, don't forget the typology. Don't forget the paranoid, non-paranoid typology, because that is important in dealing with patients. It is, Rajiv Tandon's main issue is, if you look at the publications, there's hardly any publication. I think they had like 2% of the publications focused on this. And they said it's not considered worthy of research. People are not getting anything out of it. It doesn't lead anywhere. So why keep it? But that is a researcher's point of view. I would say a lot of people who actually see these and use this, they don't publish. There are clinical psychiatrists who are not going to publish, hey, you know, my paranoid schizophrenia guy really is very different from my disorganized schizophrenia guy. They don't publish these things. They just see them in their clinical practice, and it's important for us to understand these differences between patients. Now, pseudoneurotic schizophrenia, of course, comes now under borderline personality and schizotypal personality, and maybe schizoid personality. And again, this is just an offshoot of the way history of psychiatric practice, that mainly between 1920 and 1950, psychoanalytic psychotherapy was considered as appropriate for schizophrenia. And these analysts, when they would see these patients coming with anxiety or sexual concerns, they would try the standard psychoanalytic psychotherapies for months and months and years together, and find they were not getting anywhere. They were not getting these patients any better compared to their other anxiety patients or other sexual disorder patients or hysteria patients, and said this is really schizophrenia masquerading as anxiety or as some conversion disorder or sexual conflict, etc. So they now go under different categories.
Thank you, sir. We just take up 2 more questions, I think, because of paucity of time. And I would also request Professor Grover and Dr. Adarsh to chip in with their thoughts, because of the paucity of time, we may not be able to have independent open house. There's a very interesting question by Dr. Anvi that to the speaker, that if Thomas Szasz would have been alive, do you think that he might have changed his views, considering the progress that has been made in genetics and neuroimaging? So I think, sir, your thoughts.
Well, you really don't want to get Thomas Szasz. That has to be a completely separate 1-hour lecture. No, I don't think he would have changed. I will tell you why. I actually went back to see him 25 years later. So remember, I trained with him between 79 and 82. And then somewhere in 25 years later, whenever that is, they invited me back to my alma mater to give a talk and participate in some reunion or something about the department. And Thomas Szasz was also on the panel. And I told him at that time, my experience has not changed from what it was in Bangalore when I was in NIMHANS. We don't drag people to our clinics. They come and line up in the morning. We have to send them back to their villages. Nobody is forcing anybody. And that is exactly the same. People are coming from 100 and 150 miles to see me in Richmond, Virginia, and they have schizophrenia. They come with distress. What are you talking about? Have you looked at the MRI literature? Have you looked at the fMRI literature, or the pharmacology? His answer broadly before, when I was training with him, as well as later, was the same. That, if you have somebody with the big 3D science changes, you have simply misdiagnosed an organic case. He did confess to one thing, and he said that he was not really so concerned about the condition schizophrenia being a myth. That is not the case. He was very concerned about involuntary treatment. And he came from Hungary, and during the Nazi era, his parents were persecuted, and he was very much opposed to the government doing forcible things. And so he said nobody took him seriously when he started talking about that, and therefore he decided, if I keep on saying involuntary treatment is bad, nobody listens to me, why not I simply say the condition itself just doesn't exist. That got a lot more attention. Publishers immediately published his book. He became a big hit. He made a lot of money. So he confessed to that his primary interest, his real interest was against involuntary treatment, not against anything else the patients may be suffering from. So I don't think he would have changed his answer, not in public.
Thank you, sir. Thank you. The final question that we'll take up is by Professor Mohan Isaac. He has asked whether, can you make a prediction about what is likely to occur in schizophrenia research and their outcome over the next half century?
Okay. Mohan Isaac. Hi, Mohan. I know Mohan Das was there. I thought he was the one asking. Well, that's it's a combination. If the simplistic way of saying it is that I would say three ingredients. On the biological side, a combination of genetics and imaging. I have less hopes with direct chemistry and somewhat less with pharmacology, but more with a combination of, if imaging can be superimposed on genetics, then I think there is more hope and likely progress to be made significant there. And on the psychosocial side, my last point very much applies. What makes a difference in schizophrenia is going to be how we view a person with schizophrenia as. And how, when I say we, I don't mean necessarily all the group that is listening to this talk here, how we as a society, how we as a community, how we as a government, legislators, leaders, church leaders, temple leaders, a variety of community leaders, all the people, family members, etc., how we see. Because what I find is having schizophrenic pathology is one thing, how you adapt to that, how you accommodate to that, how you adapt to that is a bigger thing. So the more progress we can make there, the more functional your patient is going to be, and the more integrated he is going to be with mainstream society. So genetics plus imaging on one side and better understanding of what exactly recovery means. It's not recovering from a hallucination or a delusion. It's recovering one's self-respect, one's dignity, and we have to assist the patient in that.
Thank you, sir. That's all the questions that we'll take up for now because of paucity of time. I'll now hand over to Professor Sandeep Grover and Dr. Adarsh Tripathi for the open house.
Thank you, Dr. Menon. I think we already exceeded quite some time. We planned to finish by 8:20, but it's already 8:33. So, I'm thankful that to Dr. Pandurangi, we have a lot of questions, and I feel sorry that we are not able to take many of the important questions because of paucity of time. But there are, I simply wish to say a few things in addition to what Dr. Pandurangi has said, that regarding the future of psychosis, what might be happening, and some other questions that is there in hope of immunotherapy. People have asked that what is the future of classificatory system? Is there a possibility of adding genetics and neuroimaging to the nosological system in the future? So to that thing, what Dr. Pandurangi has been saying, that it seems quite hopeful that this progress in genetics and neuroimaging, if they merge together, then and whatever Dr. Pandurangi was talking, that the brain project and connectome project that is happening, and the way finer neuroanatomical details of brains are being found out, although that is not happening as of now in mostly human brain, that is mostly happening in animal brain, but we soon think that it start happening in human brains also, and we'll be able to find more of the etiopathological clarity in several of the psychiatric disorders. And this finer understanding is likely to improve our diagnostic capabilities, as well as it is likely to improve our management also. I'm also I don't have evidence to produce as of now, but I'm quite hopeful that this improved understanding is likely to influence the somatic treatment developments also. That the way we are progressing in somatic treatments like magnetic stimulation therapies, or some genetic based strategies which are linked to brain stimulation. Hopefully in the future, if we think in terms of next 50 years, as Dr. Isaac sir was saying, so hopefully we might see those things coming up in psychiatry. And like immunotherapy, one participant has asked. So regarding immunotherapy, we can already see that I hope that 20 years back we would diagnose an NMDA autoimmune encephalitis only as psychosis or schizophrenia. But now we are diagnosing NMDA encephalitis separately from acute psychosis and schizophrenia. And we are treating those disorders while using immunotherapy and steroids. So in that way, that is a progress that we are able to separate a subtype of psychosis, and we are, if we are able to identify properly, we are using immunotherapy there. So in the same way, progress in etiopathological understanding will delineate the clinical illnesses, and more specific treatments might be delivered to those patients. That's what I wish to say. Dr. Grover, sir.
Yeah. Thank you, Adarsh. And I will continue from where Dr. Adarsh left, and with the question of Professor Mohan Isaac. I think if we look at what is going to happen in near future, I think lot of research is going to come. We are talking about etiopathogenesis and everything, but more and more research is going to come on neurocognition in terms of understanding the neurocognitive deficits and management of neurocognitive deficits in schizophrenia. Wherever we move in terms of etiopathogenesis, understanding the cause, but ultimately now major focus is moving towards addressing the cognitive deficits, which, as Dr. Pandurangi was saying, ultimately influences the recovery and the outcome. So we have understood this much. Earlier, we were main focus of treatment was positive symptoms. Then it was that we started realizing that negative symptoms are important, and if you don't address negative symptoms, a lot of effort has gone into looking for finding interventions for negative symptoms, but we have not succeeded there. But now, in terms of intervention, the major focus is moving towards neurocognition. So there, what others was talking about the somatic treatment, but I think we are going to have more and more of psychopharmacological measures also being experimented and evaluated in years to come, because it is now very much agreed and everybody is looking into this fact that if you can address the neurocognitive deficit, which in fact starts much before the onset of the positive symptoms, negative symptoms, and persist even after the resolution of positive and negative symptoms. So that is something which we need to understand in next 50 years. If at all we are going to have some break in the path or something we understand or we are able to provide to our patients, it will be in the direction of neurocognition. That's what I personally feel. And now in the same direction we have now started understanding social cognition. So ultimately this next 50 years is going to focus on cognitive aspects of schizophrenia rather than just on the symptomatic aspects. But the most important thing, all this is being targeted at improving the psychosocial outcome of schizophrenia. So ultimately, we the whole gist, although we are trying to do everything, at the end of the day, we will always focus on the outcome. Ultimately, how all does this all research help us in improving the outcome? The other aspect where again effort is going on, and but we have not been able to reach much, but again there is a possibility when we talk about genetics and neuroimaging, is that finding some biomarker for schizophrenia, that maybe we'll be able to find some diagnostics test, maybe I'm not very sure about that, that by which from a lab investigation we may be able to say that either this person is at a risk of developing schizophrenia or possibly has schizophrenia. But I think not in very near future, will take some more years to come, but I'm quite hopeful, and I want the research to progress in the direction of neurocognition and social cognition, so that we can help our patients better. Thank you.
Thank you, Professor Sandeep Grover and Dr. Adarsh Tripathi, for your thoughts. I think finally, what I also want to add is that in terms of treatment, we have learned a lot. We have obviously made a lot of progress in understanding schizophrenia from various aspects: genetic, immunological, the neurochemistry, neurobiological approaches, and definitely this has contributed to development of new pharmacologic agents, as Panduranga sir was saying about the trialing anti-inflammatory treatments for certain subtypes and so on and so forth. In terms of symptomatic improvements translating into real life improvements, what I have observed in my practice is that even if there is a 30-40% of improvement in the negative symptoms, or for that matter, cognitive symptoms, in real life, the meaning of that improvement is much more than what can be purely quantified in terms of the rating scales and things like that. So I also think that developing a more utilitarian model of recovery in schizophrenia is very essential to define what is the kind of improvement that patients are making, and to also reduce patient therapist frustration and other things like that. So I think it has been a very informative webinar for me personally, as well as I'm sure for a lot of participants. And also there are lots of unanswered questions to stimulate our thought process. I thank the speaker, Dr. Anand K. Panduranga sir, for a very enlightening discussion. Thank you, sir. And our respected chairpersons, Varghese Punnu sir, Dalal sir, for their thoughtful insights, and to Professor Sandeep Grover and Dr. Adarsh Tripathi, and to all the participants for their active participation. We apologize that due to paucity of time, we couldn't take up all the questions, but I'm sure all of us are available by emails to correspond further on this topic. So we will continue the dialogue, hopefully. That's all, I guess. Shall we now close the webinar, Dr. Adarsh? You have to unmute.
So,
yes, sir. If there are any final comments from Dr. Panduranga sir or any chairpersons, we can listen. Or
any concluding remarks?
No, I don't. I mean, this is an ongoing, discussion. So there is no such thing as one comment. The questions are very good ones that we did not get time to address. The differences between ICD and DSM, why there were differences, why are they coming together? There's a long history. I had some very interesting experiences sitting on that task force for DSM-4, hearing about all of this, underlying politics of all of that. So then regarding, what's going to change, I think Sandeep made some excellent comments about social and neurocognition and so on. So this is an ongoing dialogue. As you say that, people who are interested in this field should keep in touch with each other by email. You are welcome to email me. You can get it through Dr. Vikas or Dr. Tripathi, and ask me questions. I'll be happy to answer them to the extent that I can. But I want to just simply thank everyone for their participation, the organizers for organizing and inviting me. I think it looks to me that technology has worked well. And so thank you very much and have a nice evening, and also happy holidays and upcoming Christmas to those who celebrate it, and Happy New Year.
Thank you, sir. Any concluding remarks from our chairperson, sir?
Thank you, Dr. Panduranga, for this. So made the evening meaningful. Thank you, chairperson.
Thanks to all of you.
Thank you, sir.
Thank you, sir.
Bye.
Thank you, sir.
Okay.
Thank
we'll
you,
close
everyone.
the meeting now.
Thank you, sir.
Yeah.
We'll close the meeting now. Thank you.
Thank you.